Right, everyone, why don't we get started with the rest of our afternoon here, and or late morning and early afternoon. And this is the second part of the stroke guideline discussion. Now, this discussion, although it may include some controversies, as the chapter states, it's really focusing on EMS and pre-hospital either evaluation, identification, or management of stroke. So let's talk about this for a bit. So the first question is, what do the guidelines say about pre-hospital stroke screening and ultimate destination? Should the ambulance bypass local hospitals for comprehensive stroke centers? So that is a great question, and is there true value noted in the extra time spent to bypass a place where there could have been care provided? And that is a different calculus for every disease entity, whether it be STEMI, whether it be a stroke, or whether it be trauma. And we're entering in that discussion now about whether it makes sense, now that we have particularly mechanical thrombectomy, of just bypassing other facilities to get to a place where mechanical thrombectomy can be performed. And I think there's some pretty good literature that'll guide us. So really, discussing this concept, it is included in the 2018 guidelines on pre-hospital care, et cetera, but they really provide just common sense suggestions, nothing of particular importance or anything that's earth-shattering. Now let's look at abstract number 1, dispatcher stroke recognition using a stroke screening tool. So is identification and diagnosis of stroke simple? What do you think? I think most people think it can be complex. Can it be protocol-driven? Are there many patients that are identified to have a possible stroke that later we have determined that they have a stroke mimic? Yeah. So can we delegate this to someone who's potentially not medically trained or is trained at the EMT level, who is an EMS dispatcher, to use a protocol in a complex disease process, and they're not even evaluating the patient? They're on the phone with them to say stroke or not stroke, comprehensive stroke center versus not comprehensive stroke center. I think that's too much to ask of these people, quite honestly. There may be certain things we can ask of them. This may be too much. So Michigan State University, they looked at 16,382 patients. They had a stroke or TIA recognition, where they were looking at stroke or TIA recognition by the dispatchers. They used, in this evaluation, they were allowed to use any screening tool or algorithm, and it was a systematic review of 7 studies. The positive predictive value for them to be able to identify stroke or TIA was 42% to 68%. That's the range in the studies they reviewed. So basically it said even in the top performing study, 68%, it's not good enough. So EMS dispatchers are probably not going to be able to do this for us unless there was more extensive training or some way to simplify this. However, all the studies had a moderate risk of bias, so none of them were high-quality studies. But I don't think if the quality was improved, that would have showed better predictive value from these algorithms used by EMS dispatchers. So abstract number 2, a systematic review of stroke recognition instruments in hospital and pre-hospital settings. So the systematic review included 18 studies, 3 conference abstracts, and again, using 7 stroke prediction tools. I'm not going to go through all of them here, and they're all very brief, but the sensitivity was highest for the Cincinnati pre-hospital stroke scale, between 44% to 95%, depending on how it was applied, and for the FAST scale, 79% to 97%. Easy to follow for sure, right? So we have to make sure that we know how to apply them, and we provide appropriate training. FAST is really easy, of course. So you've got facial drooping, arm weakness, speech problems, and the recognition of time sensitivity of stroke. It's so simple, but still there was such a wide range of performance there. And the LAPSS had the higher specificity at 48% to 97%. So still not great performing there. No single instrument could be recommended based on this systematic review. So again, another article that says we probably can't delegate this very, very important function to EMS or EMS dispatchers. So the next article is about, as abstract number 3, estimated impact of emergency medical service triage of stroke patients on comprehensive stroke centers. This is interesting. So if we decided that, listen, if we think you have a stroke, and getting you to a comprehensive stroke center that will have mechanical thrombectomy available, so therefore if you need it, If you need it, you'll have it available. What would that do? And they reviewed this and found that the annual case volume for comprehensive stroke centers would rise by 359%. What are they going to do with all those patients? And as we'll talk about in subsequent abstracts, are all those transfers that they currently receive, are they warranted or are they futile? Do they really need to get there? And quite honestly, there's a good portion of them now that probably don't need to go. All right, so the next couple of abstracts here, it's abstract 4 and 5, and 4 really speaks to what was developed in this French paper in 5. So can you really do drip and ship, or should you not do that? This is the concept. I'll focus more on abstract number 5. What they found was patients treated under the drip and ship paradigm also benefit from bridging therapy with no statistically significant difference compared with those treated directly in a comprehensive stroke center. So what that means to me is, so they're going to get their TPA and their mechanical thrombectomy. Was there a difference of them getting all of that treatment in the comprehensive stroke center, or could they do some of that treatment on the way to the comprehensive stroke center? And what they said was the infusion time is the infusion time. I don't think many people are going to do the mechanical thrombectomy before the infusion is completed. You're giving the treatment, then you're going to do this. So I suspect that's the way most algorithms and protocols are going to go. So you're probably not losing anything if the infusion time is longer than the transport time. So that's why I think they came to that conclusion, and it does make sense, and it should make us feel comfortable that if you are at a place and you do drip and ship to a place that can do thrombectomy, that you may, implied by these two articles, that you could have the same outcomes as if you got all of that care at the Comprehensive Stroke Center. All right, the next question. Aren't stroke mimics common, and shouldn't that be a factor in the consideration of pre-hospital system redesigns? Abstracts 6 through 9, and I think we need to spend some time here. And of all the areas in stroke, I think this is fascinating because as we move fast and hard toward trying to intervene with patients with suspected ischemic stroke, we run into the situation that we discussed yesterday, that we might actually treat patients who do not have the indication we can harm people. Now, there was one study that was published a couple of years ago, and it actually stated, well, when stroke mimic patients get TPA, they have a very low risk of intracranial hemorrhage. So therefore, we shouldn't worry about it. My perspective is much different. If you have a stroke mimic, TPA is not indicated at all, so you have no potential for benefit. So therefore, any adverse relationship of delivering TPA is unacceptable. But there is the sentiment out there that going fast and giving patients with stroke mimics TPA is an acceptable collateral damage to this process, and I don't think that it is. You'll have to make your own decision, but the evidence is pretty clear that there are a lot of stroke mimics. So let's look at abstract number 6, 1-year prospective study, and they looked at the rate of stroke mimics in patients admitted within 4.5 hours of symptom onset. 1,361 consecutive cases, and they were all screened with an MRI to make sure that they knew exactly what they were dealing with. 38% of these patients had stroke mimics. 38%. That's a lot of people. And they were going down the pathway of we think you have a stroke. The most common were complex migraines, 19%. So think about that. That these presentations could very much look like a stroke in their complex migraines. Psychological disorders, number 2 at 17%, and peripheral vertigo at 12%. The pre-hospital FAST assessment that we talked about briefly, 41% positive in stroke mimics. So the stroke mimic people are going to be positive too. If we identify this in the pre-hospital phase, this may get called in as a stroke because they're positive fast, and we have to be cautious to make sure that we're not treating a stroke mimic. The next one, abstract number 7, retrospective cohort, 1,165 patients admitted to a hyperacute stroke unit. What I think that means, does anyone have a hyperacute stroke unit? I think that means that basically these are the acute strokes and you're deciding how you're going to intervene with them emergently. I don't think the stroke is necessarily more important than other strokes that we would call acute. I'm not sure, but that's my interpretation of the term. Medical mimics, 14%. This is interesting. Functional mimics, 8.4%. So the medical mimics were the organic things. Pathology, like we talked about before in the other article, things like complex migraine or peripheral vertigo. And some studies have even found peripheral neuropathy to be an important contributor here as well. But functional mimics are things that aren't necessarily organic or medical problems. They may be mental health related, maybe something else. But someone presented in a way you couldn't diagnose anything, but ultimately they found that this was the case. And for whatever reason, the association was in younger patients and in female patients, they had a higher number of these cases. Whether that would carry out in other environments or not, we don't know, but it was reported by the authors here for you to consider. Abstract number 8. Childhood stroke mimics. So this is pretty scary, and there are some kids that actually do have stroke. And so they looked at two groups, and there was retrospective evaluation and prospective evaluation. And from the year 2009 to 2010, they identified 280 with stroke mimics. 280, and they had to go from 2003 to 2010 to find 102 with confirmed ischemic stroke, TIA, or hemorrhagic stroke. And what did they look like? So the results were strokes were ischemic in 55 children, hemorrhagic in 37, and a TIA in 10. And the most common mimics were migraine again, 84, seizures 46, Bell's palsy 29, conversion disorder 18, and syncope 14. So it really does happen out there. What was helpful, I thought, the independent predictors of any one of those types of stroke were good. They had good health during the week prior to it, so they had nothing going on, and the odds ratio was 5.76, meaning they were completely fine, and then this happened. And then arm weakness and odds ratio of 8.66. You're not going to have arm weakness with Bell's palsy. You aren't. So clearly there's something significant going on there. Facial weakness, despite the fact that you may see this and should see it with Bell's palsy, it's going to look different. The odds ratio was 2.94. And inability to walk, the odds ratio was 3.38. So if you look at those factors, we don't need to build a prediction tool or clinical decision instrument around it. Just be aware of it. If a kid presents with hard neurological symptoms in that way, can't ambulate, and these type of things, there is a strong likelihood it really is a TIA, ischemic stroke, or a hemorrhagic stroke. You need to be aware of that. All right, and the last one in this section is abstract number 9. It's a retrospective analysis of 950 patients, 18 months worth of EMS transports for suspected stroke, and 405 patients, 42.6% actually were stroke mimics. 55%, so over half, were neurological mimics, and the most common were seizures, migraines, and peripheral neuropathy. So these common themes seem to be running through these abstracts of what may create mimics. And the rest were non-neurological. Cardiovascular reasons, 14.6%, and mental health, 11.9%. But the take-home message here is there are a significant number of people that are considered to have probable or at least possible ischemic stroke that ultimately do not have this pathology and therefore should not be treated with TPA or mechanical thrombectomy. We need to have the right answer before we know what the right treatment is. And we need to go as fast as we can, but not so fast that we can't get the right answer. All right, the next question: can patients with large vessel occlusion be reliably identified in the pre-hospital setting? Well, this is a big challenge as well, and the answer is probably not. Abstract number 10, systematic review for the 2018 guidelines for the early management of acute stroke. So they looked at evaluating, again, large vessel occlusion prediction instruments for rapid transport so they could say, listen, if you knew that this was an LVO, large vessel occlusion, you should go to the right kind of place and get mechanical thrombectomy. Just do it. 36 relevant studies, only 4 of the 36 were actually pre-hospital studies. The most commonly used tool was the NIH stroke scale score, and no scores predicted the large vessel occlusion with high sensitivity or high specificity. It didn't work, and this is scary. The probability of a large vessel occlusion with a negative screen of any of this was more than 10%. You would miss at least 10%. That is not a reasonable level of misdiagnosis and mistriage. Abstract 11 is really quick, and it just speaks to a local intervention. So Los Angeles implemented the Los Angeles motor scale. They said with 90 patients it performed really well, and it performed better than 7 other scales. It's just the abstract is here, so it lets you know that the literature is evolving in this area, and there may be tools that are coming that may be more beneficial. But right now, the literature, I think, is pretty clear. There is no way to adequately screen for stroke and triage, and especially not large vessel occlusion, either by EMS dispatchers or in the pre-hospital phase of the care that's delivered. We don't have a way to do that that's appropriate. The next question, what happens to stroke patients who arrive at local hospitals or primary stroke centers and then are transferred to the Comprehensive Stroke Center? So 2 abstracts here. The first is abstract number 12, University of Illinois at Chicago. 105 patients, 54.7% did not undergo thrombectomy after transfer. Excuse me. So they got there, and as I mentioned earlier, some of the transfers were unnecessary and maybe were burdening the Comprehensive Stroke Center. The primary reason was that vascular imaging on arrival said, you know what, we really don't think it's going to be the right type of vessel, or they're not applicable. Abstract 13, this is from Madrid, Spain. It's an observational prospective registry evaluation, frequency of fetal transfers to stroke centers, and this was scary. 41% of all transfers were just unnecessary. They didn't do anything differently with them. But the explanation, I think, is a little bit better than the last abstract. So when they got their TPA at the former facility, by the time they got to the Comprehensive Stroke Center, they revascularized. They were better. So you wouldn't then move on with mechanical thrombectomy. There was good reason for it. But then in another, and that was 48%, and then in another subset, when they repeated imaging at that point, 32%, they said, you know what, we don't think you're really a good candidate. You're not going to benefit from this. So a lot of people are referred to comprehensive stroke centers who ultimately don't benefit from the end result of intervention. But I will have to say that the evaluation probably does provide a higher level of investigation of their disease and options. And if you don't allow them to have that investigation, if they need additional options, they wouldn't have them available. So I can't say that every case that doesn't get mechanical thrombectomy should not have been at a comprehensive stroke center. I think that's too far-reaching. All right. The next question, does the volume of revascularization procedures performed in a hospital lead to better outcomes? It's one abstract. I think it's really good. So how many of you golf? Because I know we're in a golfing area right now. You're a few golfers. Are the better golfers the ones that golf more or less? I know there are exceptions at both ends of the spectrum, but generally speaking, you're a better golfer if you have more time to golf. The same is true with these procedures. If you don't do very many of them, that is reflected in your outcomes. If you're really good at this and you're really good at selecting the right patients, etc., you're better at it, and that's what this abstract reflects. 8,533 patients treated with endovascular revascularization. Low volume versus high volume is what they looked at. The overall mortality rate was 15.6%. If you were transferred versus non-transferred, interesting, 18.6% versus 14.9% mortality. So they said when you transferred a patient, there was an inherent increased risk that increased their mortality. And that's different than the French study we talked about from Abstract 5, the bridging study. It's fine if you send them. It wasn't hurting them. This article says if you actually transfer them, and you have to, that may increase their risk. But listen to the rest of the data. I think it's pretty compelling. Low volume, medium volume, high volume for procedures, mortality was 19.7%, 14.9%, and 9.8%. And if you admitted to a low volume place versus transferred to a high volume place, both places that do procedures, 20.4% mortality at the low volume place versus 10% at the high volume place. So the only interesting nuance here is they said transfer seemed to increase mortality to a certain extent, but it was way offset, significantly offset by the benefit if you had a high volume in experience with mechanical thrombectomy, and probably even the moderate volume. But the low volume places, it may not be of benefit, so that may be where a lot of those numbers came from. All right, the next question, and we're getting close to the end of this discussion. I don't want you to be sad, but Stroke Controversies is almost done for this course. So what about mobile stroke units? Is there any benefit to just doing the CT in the ambulance? Does anyone have a mobile stroke unit in your area? You do? And there's some infrastructure cost here. And it's interesting that there are some very strong proponents for this concept, that people think it is really a great idea. A couple of these abstracts, 15 and 16, will be covered in the telemedicine chapter. I'm not going to duplicate them here, except just to say that this is a newer concept. And yes, there are people who say that there may be great benefit, but boy, this is moving significant resources into an ambulance. You need somebody who is trained to be a CT tech along with the EMS crew. And I know you're not going to use this for every patient, and you're not going to use it for every presentation. It has to be limited to those who you have suspected ischemic or who have suspected ischemic stroke. Abstract 17, I will mention, it's a review article of the concept, and basically it says, wow, this is great innovation. This is really neat, and this is a really cool approach to identifying ischemic stroke early, and it may have benefit. But there is more prospective data that's going to be required to answer the cost-effectiveness question. We don't know if all this infrastructure is really necessary, if it's really going to have a significant impact, how many patients will be seen through this process. I think low-volume rural communities could probably never make this argument, but high-volume urban communities may be able to, and I think individual communities and systems will have to make their individual choices. So the last question and last abstract in this section is, telemedicine seems to be gaining popularity. What do the ASA and AHA guidelines say about it? Any supportive literature? Well, they first say telestroke consultation is probably a good thing. And if you don't have availability of a stroke neurologist and you don't have availability of telestroke, then phone consultation is acceptable, and they said that's a Class 2B Level C recommendation. We don't need a recommendation to tell us that if we don't have certain resources, we will just use the telephone. But I'm amazed that they decided to give us a recommendation there and then give it a grade for level and quality of evidence. So basically, they said that there is a potential for benefit in abstract number 18, which is from Kaiser, Northern California, and they looked at their own telestroke care network. And it's interesting, they said that when they implemented this, they did not see increased rates of symptomatic intracranial hemorrhage. They ended up giving TPA to more patients, but when you look at their data, it says something slightly different. So pre-telestroke population had an intracranial hemorrhage rate of 2.2%. The population before and after, the after implementation showed a rate of 3.8%. With an unadjusted odds ratio of 1.6. There was a difference. So I don't know if it's because when you use this network, you are now increasing the number of patients, although this is based on percentage, and increase the number of patients exposed, or does the system in and of itself push beyond the levels of acceptability and indication where you put more patients at risk than were normally at risk before this program went into place? That's hard to say, but the numbers are different.